Alright, so you guys, we are now down to our last topic, which is your liver function. So before we proceed, let's have a short review regarding the functions of the liver. So as what we all know, the liver is one of the most important organs in the body, performing synthetic functions, storage functions, detoxification, secretion and excretion, and at the same time that of your conjugation functions. So, it is important, of course, to know that if there is a disease affecting the liver, its functions will also be affected. That's why we are using certain tests to assess each of these functions of the liver in order to evaluate whether there's something wrong with the patient's liver. So, if you remember, the synthetic function of the liver will include the synthesis of macromolecules such as that of your carbohydrates, your proteins, and your lipids. As for its storage function, so the liver is where glucose could be stored in the form of glycogen. And also, your liver is the site for the storage of fat-soluble vitamins, which includes, of course, your vitamins A, D, E, and K. Also, the liver functions for detoxification primarily of certain drugs and at the same time that of your ammonia. Because ammonia is of course a toxic waste product to which the liver converts it into a less toxic product that is your urea. For the secretion and excretion and at the same time the conjugation function of your liver, these three are somewhat intertwined with one another and we'll talk about it more as we go through the questions under the liver function. Okay, so let's have the first question. The analytes used to evaluate the synthetic function of the liver include 1. Albumin, 2. Prothrombin time, 3. Total protein, 4. Gamma globulin. So is it A, 1 and 3, B, 2 and 4, C, 1, 2 and 3, or letter D, 1, 2, 3 and 4? As what you could notice, the choices given here are all types of protein. And we have mentioned that the liver is the site of synthesis for almost all types of proteins. May exception lang ta guys. So, ano na ang mga proteins nga wala ginasynthesize sa liver? So, that would include, of course, the adult hemoglobin, and another protein which is not synthesized in the liver would be our gamma globulins. Again, your gamma globulins. Take note, guys, that the adult hemoglobin here is being synthesized in the bone marrow. We have to be careful because when we talk about of hemoglobin, diba, if you remember, there are 3 periods of hematopoiesis. So we have your mesoblastic, your hepatic, and that of your myeloid period of hematopoiesis. So a certain type of hemoglobin, which is that of your fetal hemoglobin, is actually synthesized by the liver, particularly during the hepatic period. But again, as I have emphasized, it is the adult hemoglobin that is included in the exceptions of those proteins synthesized by the liver, since this is being produced in the bone marrow. And of course naman, your gamma globulins or our antibodies or immunoglobulins, they are not synthesized by the liver because they are formed in the lymphocytes, particularly that of your B lymphocytes. So with that, the correct answer for this question will only include your albumin, your prothrombin time, and your total protein. Miss, what about yung prothrombin time? Remember that your prothrombin time is used to monitor if there is a deficiency of the coagulation factors included in your extrinsic coagulation pathway. So coagulation factors are also proteins being synthesized in the liver. That's why we include number 2, which is your prothrombin time, in our answer here. So the correct answer would be letter C, 1, 2, and 3. So talking about the liver synthetic function, note that the liver has extensive synthetic capacity. It is responsible for synthesizing many biological compounds, including that again of your carbohydrates, lipids, and proteins. With carbohydrates, guys, there are 3 processes to which the liver contributes to the production of this macromolecule. So it could contribute to carbohydrate synthesis through the process of gluconeogenesis. Production of this glucose comes from non-sugar carbohydrates such as that of your pyruvate, your lactic acid, or even that of your amino acids. So gluconeogenesis usually happens when the patient is already depleted of the stored form of glucose, which is that of your glycogen. So wala nakuhaan nga iban nga source ang liver, so wala sa choice. Mangita gid siya sang non-sugar carbohydrates para lang makasynthesize gyapon sang glucose. And then we also have your glycogenolysis, or the breaking down of your glycogen. So of course, if yung carbohydrates coming from the diet of a certain individual is already used up by the body, the liver will have to break down the stored form of glucose, which is your glycogen. And we also have here your glycogenesis, which is the formation naman of your glycogen. Again, this is the stored form of our glucose. What about the synthesis of lipids? So take note that the liver could also be a site for the synthesis of your fat. That's why we have what we call your endogenous fat. Also, we have here the synthesis of phospholipids, and as what I have mentioned, guys, the cholesterol found inside our body usually comes from that of the liver and not from the food that we eat. In fact, 70% of the cholesterol found in the body is actually synthesized by the liver. And then we also have here protein synthesis. So again, almost all proteins are synthesized by the liver except for those two, your adult hemoglobin and at the same time your gamma globulin. So albumin together with other proteins such as that of your globulin, your alpha-2 macroglobulin, and the rest of your APRs are all synthesized in the liver. Also included would be that of our coagulation factors. That's why when you perform your PT, your prothrombin time, and your APTT or your activated partial thromboplastin time, we could also assess the synthetic function of the liver. So if prolonged yung PT or APTT, that would mean that there is coagulation factor deficiency, which could be caused by a problem with the synthetic function of the liver. So tests that can be performed include serum protein measurements and that again of your prothrombin time. Next question. Unconjugated bilirubin is transported from the reticuloendothelial cells to the liver by letter A, albumin, B, haptoglobin, C, transferrin, or letter D, prealbumin. So very easy, your unconjugated bilirubin, or that is your B1, which is a product of hemoglobin breakdown, will be transported from the reticuloendothelial cells to the liver by that of your albumin. Because remember, the unconjugated form of bilirubin is considered to be water insoluble. Again, it is considered to be water insoluble. So this means it has to have a carrier molecule in order for it to be transported from the reticuloendothelial cells to that of the liver, wherein it would be conjugated. As for the other choices, just a quick review. For your haptoglobin, this on the other hand is the one which transports your free hemoglobin. Again, this is the carrier particle for your free hemoglobin. Usually, your haptoglobin increases in concentration during intravascular hemolysis, wherein there would be increased concentration of free hemoglobin in the plasma. So just like your albumin, your haptoglobin will also deliver hemoglobin towards the liver where it would be further broken down. Next, what about yung transferrin? So very easy, transferrin naman is the carrier particle for iron. Again, transferrin is the carrier particle of iron. So specifically, your transferrin will be the one to bind with iron that is recently absorbed by the small intestine. And your transferrin will deliver iron to certain sites which requires its presence for the synthesis, particularly of certain molecules such as that of your hemoglobin. So yung primary target ni transferrin na pag-deliveran ng iron would be that of your bone marrow cells, wherein you could find the developing RBCs which requires iron for hemoglobin synthesis. And then we have your pre-albumin, also known as your transthyretin. So this, on the other hand, is the carrier particle for your thyroid hormones, which includes your thyroxine or your T4 and also that of your triiodothyronine or T3. Okay? Let's further talk about your unconjugated bilirubin. As what I have mentioned, your unconjugated bilirubin is also known as B1, as the water-insoluble bilirubin, and as the indirect bilirubin. This term, indirect bilirubin, is actually related with its reaction to one of the tests utilized to measure your B1. So later, i-discuss na siya. So this form of bilirubin is insoluble in water and cannot be removed from the body until it has been conjugated by the liver. So between the unconjugated and conjugated bilirubin, it is actually yung conjugated form that is readily eliminated out of the body since it is filtered by the kidneys because it is water soluble. On the other hand, the unconjugated bilirubin could not be filtered by the kidneys because in the first place, it is water insoluble. That's why very important yung conjugation process that takes place in the liver. So take note that unconjugated bilirubin is considered as the product of hemoglobin metabolism, particularly if hemolysis occurred in the extravascular component or what we call as your extravascular hemolysis. So extravascular hemolysis usually happens normally as part of the regulation of the lifespan of your red blood cells. Remember, diba, that red blood cells are only viable for approximately 120 days. Once they are senescent or once they are already old, they will be delivered to the reticuloendothelial system, particularly that of your spleen, to undergo sequestration. And when the macrophages of your spleen sequesters these red blood cells, of course, hemoglobin contained by the red blood cells will be freed and it has to be metabolized. So remember that hemoglobin has two components, the heme and the globin component. Yung globin component, guys, which is composed of proteins, particularly that of your amino acids, will be recycled by the body. So the amino acids in the globin component of your hemoglobin will be recycled back to the amino acid pool so that later on, it could still be used by the body. What about yung sa heme na portion? Note that yung heme portion is composed of your protoporphyrin 9, and that of your iron. So between these two, guys, your iron is also recycled to be utilized in future processes which requires its presence. So basically, yung hemoglobin metabolism will include the metabolism of the protoporphyrin 9 here, okay? So what happens once hemoglobin is already freed during RBC sequestration? So this will be acted upon by the enzyme heme oxygenase and convert it to that of your biliverdin. Biliverdin will be reduced to your unconjugated bilirubin through the action of biliverdin reductase. So thus, we have here your B1. So we say again that your B1 or unconjugated bilirubin is the product of hemoglobin breakdown. Now, since this is considered as a waste product coming from hemoglobin metabolism, it has to be eliminated from the body. But the problem is it is water insoluble. So anong himuunta? Himuunta siya nga water-soluble through the process of conjugation, which is why this should be delivered towards the liver. And this is where your albumin will perform its function of carrying your B1 from the reticuloendothelial cells towards that of the liver. But remember, once the B1 enters the liver, your albumin will let go of your B1 and another carrier particle particle will receive that of your B1. This carrier particle now will be that of your ligand. So if ang question, carrier particle for B1 from reticuloendothelial cells to the liver, that's your albumin. But if you are asked the carrier particle of B1 in the liver, so it's no longer albumin, but rather it is now your ligandin. So what's the function of your ligandin? Diin niya na i-deliver si B1. So ligandin will now deliver or transport that of your B1 to the endoplasmic reticulum of your hepatocytes, wherein the conjugation process will take place. So conjugation would require the presence of the enzyme glucuronyl transferase, which will facilitate the addition of two glucuronic acids to that of your B1, converting it to the conjugated form, which is your B2 and is now water soluble. So your B2 here will be secreted by the liver together with other substances such as that of your bile salts, and they will be secreted as bile. So di na siya makadto. This will be delivered towards that of the small intestine. So in the small intestines, we have of course the presence of our normal flora, and these normal flora will act upon your B2 to convert it to that of your urobilinogen. Urobilinogen will be further converted to that of your stercobilin or your urobilin in the colon or in the large intestines. And it is your stercobilin or your urobilin which gives color to the stool. That's why later, if we talk about post-hepatic jaundice associated with obstruction along the biliary duct, prevents B2 from reaching the small intestines, we'll know that the stool sample of patients with post-hepatic jaundice are actually pale in color. Kaya of course, kung hindi ma-deliver si B2 towards the small intestines, it will not be converted to urobilinogen and there will be no presence of stercobilin to give color to the stool. Now, although most of this urobilinogen are further converted to stercobilin, remember guys that 20% of it, together with some B2, will actually re-enter the circulation through the enterohepatic circulation. Okay? So what happens is that urobilinogen and B2 will be delivered back again to the liver para masikret sila. Or a very small portion of this will enter that of the systemic circulation, wherein urobilinogen and B2 will be readily filtered by the glomerulus once they reach the kidney. And thus, we could also test for the presence of urobilinogen and B2 in urine samples. And testing for the presence or the level of urobilinogen and B2 in urine samples could actually help us differentiate the particular cause why our patient has jaundice. So later, we could classify jaundice again as prehepatic, hepatic, or post-hepatic. Moving on, the administration of bromsulfonane dye is used to evaluate which liver function: A. Synthetic, B. Conjugation, C. Storage, D. Excretion. So administration of dye is actually used to evaluate the excretion function of our liver. So for the liver excretory function test, there are actually several tests that we could perform. So we could also check for the bilirubin levels, since we have mentioned that bilirubin is also part of the substances being secreted or excreted by the liver, and same with that of your urine urobilinogen. But a more common test to assess the excretory function would be the dye excretion test, particularly making use of your bromsulfonane dye. So the dye will be administered intravenously. And of course, if nagupod na siya sa circulation, one of the organs to which this dye could reach would be that of your liver. So remember, anything that is not needed by the body will be eliminated from it through the actions of the liver. So we are expecting that once the liver senses the presence of bromsulfonane dye, it will just eventually excrete it out of our system. So there are two techniques for the bromsulfonane dye administration. So we have here your Rosenthal White test and your McDonald test. So for Rosenthal White, we make use of a lower dose at 2 milligrams of bromsulfonane dye per kilogram of our patient. After administering the dye, we have to collect blood from the patient 2 times. So after 5 minutes and then after 30 minutes. So if there is no problem with the excretory function of the liver, normally after 5 minutes, only 20 to 50% of the administered dye will remain in the circulation. The other 50 to 80% will be already eliminated out of the circulation. And after 30 minutes, we expect that the bromsulftalin dye will no longer be present in the circulation. On the other hand, let's have your McDonald technique. So yung dosage is at 5 milligrams of the dye per kilogram of the patient. Blood is only collected once, and that is after 45 minutes of the administration of the dye. So after 45 minutes, if there's no problem with the excretory function of the liver, less than 5% of the dye should remain in the circulation. Next, the clinical manifestation of jaundice develops when the total bilirubin levels exceed A. 1.2 milligrams per dl, B. 17 micromole per liter, C. 3 milligrams per dl, or letter D. 20.5 micromoles per liter. So usually, we consider jaundice to be clinically significant if the total bilirubin level will exceed 3 milligrams per dl. So let's talk about jaundice. So jaundice is the term used to describe or to refer to the yellow discoloration of the skin, the eyes, and the mucous membrane, particularly because of the accumulation of your bilirubin. So it could be either conjugated or unconjugated na bilirubin. Now, total bilirubin here refers to the sum of the conjugated and the unconjugated bilirubin. But take note guys yung total bilirubin in the serum is mostly composed of the unconjugated bilirubin. As what you could see here, yung total bilirubin na reference range is at 0.2 to 1 milligrams per dl. And then most of it is actually in the form of your unconjugated bilirubin, which is normally at around 0.2 to 0.8 milligrams per dl. Conjugated bilirubin, on the other hand, is usually 0 to 0.2 milligrams per dl because remember, if present siya sa systemic circulation, it will just be readily filtered by the kidneys since it is water soluble. Now, there would be instances wherein the patient will have a total bilirubin level ranging from 1 to 1.5 milligrams per dl. So, based on normal range ni total bilirubin, 1 to 1.5 milligrams per dl is higher than normal. But this level is still not considered to be clinically significant. So, hindi pa siya indication that there's really something wrong with that of your liver. We consider lang na clinically significant na yung level ni total bilirubin if it already exceeds 3 milligrams per dl. Aside from that, other values that we have to know regarding the levels of your total bilirubin are as follows. The panic value of our neonatal hyperbilirubinemia is at greater than 15 milligrams per dl. Again, panic value for neonatal hyperbilirubinemia is at greater than 15 milligrams per dl. So of course, compared to adults, neonates are expected to have a higher level of bilirubin since yung liver nila is not yet fully developed. So if you test neonatal serum, the total bilirubin will be higher than 1 milligrams per dl, and that's normal. But we consider it to be clinically significant or a panic value if it is greater than 15 milligrams per dl. Aside from that guys, bilirubin level in infants reaching 20 milligrams per dl will now increase the risk of developing what we call as your kernicterus. So kernicterus is defined as the accumulation of your unconjugated bilirubin to the nerve tissues or your brain tissues, which is very fatal as this could cause death in infants. Now, we have mentioned about jaundice being classified as prehepatic, hepatic, and posthepatic. So, this classification is based on the specific cause of jaundice. Why is it that we have an increased B1 or increased B2? So, for prehepatic jaundice, this occurs when the problem is prior to liver metabolism. So, there's no problem with the conjugation, the uptake and the secretion function of your liver, but rather a certain condition led to increased production of your B1, which will of course lead to high concentrations of your B1. So prehepatic jaundice is associated with hemolytic diseases. Kaya syempre, if there is hemolytic diseases, your RBCs, although they are not senescent, will lyse, and this will increase the level of free hemoglobin, and free hemoglobin will eventually be broken down, producing that of your B1. So nagsaka ang B1 not because nga may problem ang liver, but it's because nga nag-increase ang levels ng free hemoglobin. Also, in cases of ineffective erythropoiesis. So of course, if the type of red blood cells being produced by the bone marrow are abnormal, it is the job of your spleen to destroy such types of RBCs, because we could not allow abnormal red blood cells to be present in the circulation. So these abnormal RBCs will be sequestered by the spleen, and sequestration again will increase hemoglobin breakdown and eventually increase B1 level. Also, in the case of congestive heart failure, which lessens the amount of blood supply towards the liver. So if the amount of blood is lessened, syempre, jutay man ang amounts ng blood nga ma-process ang aton nga liver. So that's your prehepatic jaundice. Then we have your hepatic jaundice, which is caused by intrinsic liver defect or diseases. This time, ang problem naman natin is yung liver na nga, okay? So what could be the problem in the liver? So there are three particular causes, or there are three particular problems in the liver that could be associated with hepatic jaundice. Number one, impaired yung kanyang B1 uptake. Second, defective yung conjugation. And third, abnormal yung kanyang secretion. So, pwede na walang problem with conjugation and secretion, however, mag-accumulate pa rin yung B1 since hindi siya tinatanggap effectively ng liver. Or it could be that B1 is efficiently taken up by the liver pero defective naman yung conjugation or defective yung secretion. And of course, post-hepatic jaundice will be caused by obstructions preventing the flow of B2. So, there's no problem occurring prior to liver metabolism. The liver is also not damaged. However, your bilirubin, particularly your conjugated bilirubin, still could not reach the small intestine because there would be obstructions along that of the biliary duct. So, these obstructions could be caused by bile duct stones, cholestasis, cancer of the bile duct, or cancer of the pancreas, sclerosing cholangitis, and in cases of biliary atresia. Let us now move on to the next question. Which of the following is a characteristic of hemolytic jaundice? A. B1 level is greater than normal. B. Both B1 and B2 are greater than normal. C. B2 level are greater than normal. Or letter D. Both B1 and B2 are normal. So we have already mentioned about hemolytic jaundice being classified as prehepatic jaundice. Now, when we talk about of jaundice, di ba, it's either B1 or B2 ang nagsaka. So, for each type of jaundice, prehepatic, hepatic, or posthepatic, there is a particular type of bilirubin that increases. And in cases of prehepatic jaundice, between B1 and B2, it is your B1 that becomes higher than normal. So, for this question, the characteristic of hemolytic jaundice would be letter A. B1 levels would be greater than normal. For letter B, guys, if both B1 and B2 are greater than normal, this will be associated with your post-hepatic jaundice. But actually, when we talk about of post-hepatic jaundice, mas higher ang tendency nga nagsaka si B2 compared kay B1. If either B1 or B2 is increased, then it could be because of hepatic jaundice, and depende na siya kung ang naging problem is with the uptake, with the conjugation, or with the secretion of your bilirubin. So to further differentiate the types of jaundice, let's have here this table. So we have here the type of jaundice, and of course, the classification if what type of bilirubin is increased. Would it be your conjugated or your unconjugated bilirubin? Syempre, sa total bilirubin, kay jaundice ni siya, we expect that in all types, your total bilirubin will be higher than normal. So let us try to differentiate each of these types of jaundice. So for prehepatic jaundice, again, yung problem, di ba, is nagtaas ang aton nga B1 because of certain conditions such as hemolytic diseases, or decrease blood supply towards the liver. So that means guys nga even though nagsaka si B1, once nga naka-reach lang saya sa liver, they will be eventually conjugated by the liver. So ano na di ang gasaka nga types ng bilirubin? So it's usually that of your unconjugated bilirubin or your B1. For your conjugated bilirubin, it could either be normal. Particularly, manormal ni siya guys if wala man lang problem sa conjugation process ni liver. Or sometimes, pwede ni siya mag-increase if tamaan gid kataas ang levels ng B1 nga gakasaturate yan na ang ability ni liver nga i-conjugate si B1 to B2. Okay? Now, for the hepatic jaundice naman, as what I have mentioned, it is either B1 or B2 ang masaka, depende kung ano yung specific nga problem. In cases of Gilbert disease and Crigler-Najjar syndrome, yung problem ng ating liver is with regards to the uptake of B1 or it could be with the conjugation na process. Specifically, in Gilbert disease, yung problem natin dito is with the uptake of B1. So, wala nga ka-take in sang liver ang B1 coming from hemoglobin metabolism. That's why for Gilbert disease, although it is hepatic, but it is associated specifically with an increase of your B1 and normal levels of your B2. Since again, yung problem is with the uptake. Now, for Crigler-Najjar syndrome, also, increase man ding aton nga unconjugated bilirubin, pero nubo ang aton conjugated bilirubin since yung problem dito is with regards to the presence of your glucuronil transferase. Patients with Crigler-Najjar syndrome are actually deficient or absent gidya ang enzyme that is glucuronil transferase in their system. So, hindi maka-facilitate conjugation. That's why miski gina-take up ang B1, ma-accumulate siya gyapon kay wala conjugation process nga ga-occur. As for Dubin-Johnson and Rotor syndrome, the problem here is with the secretion of your conjugated bilirubin. So, in these two diseases, there's no problem with B1 uptake and at the same time, normal man ang pag-conjugate sang liver, pero hindi siya mapagwa sang imo nga liver since again, yung problem is with the secretion function. So that's why for Dubin-Johnson and Rotor syndrome, the unconjugated bilirubin level will be normal but increased yung conjugated bilirubin level. As for the jaundice of newborn, again, the liver is not yet well developed, so the conjugation process is less efficient. So it could be associated with increased unconjugated bilirubin and normal conjugated bilirubin. As for the post-hepatic jaundice, both conjugated and unconjugated bilirubin could increase, but as what I have mentioned, the conjugated bilirubin increases at a higher rate compared to that of your unconjugated bilirubin. So in cases of post-hepatic jaundice, pwede nga si unconjugated bilirubin is still within normal levels, okay? And guys, I highlighted here for both your prehepatic and posthepatic yung major type of bilirubin that increases in this case. So prehepatic, again, is associated with accumulation of unconjugated bilirubin. That's why unconjugated bilirubin is also termed as the prehepatic jaundice bilirubin. For posthepatic naman, yung major type of bilirubin that increases in the circulation will be your conjugated bilirubin. That's why your conjugated bilirubin is also termed as the posthepatic jaundice bilirubin or the obstructive type of bilirubin. Aside from the type of bilirubin that increases in the circulation, we could also assess the levels or the presence of urobilinogen in the urine, which is very important, particularly when the patient has post-hepatic jaundice. So as what you could see here, guys, a bile duct obstruction, which is a cause of post-hepatic jaundice, urine bilirubin will be 3+ or very high ang levels ng bilirubin sa sample. It's because again, sa post-hepatic jaundice, ga-accumulate si conjugated bilirubin sa circulation. And since this could be readily filtered by the kidney, ma-increase man ang iya nga level sa urine sample. What about yung urine urobilinogen? Nga anormal siya. Remember that your urobilinogen will only be formed once your B2 reaches that of your small intestine. But in the case of your bile duct obstruction, B2 does not reach the small intestine. So B2 is not converted to urobilinogen, which is why wala man urobilinogen nga ma-re-enter sa circulation and reach the systemic circulation to be filtered by the kidneys. Next, we have here yung liver damage, which could be a cause of hepatic jaundice. So, sa urine bilirubin, it could either be positive or negative. Depende kung ano ang nagsaka. Kung B1, syempre, ma-negative ng imo urine bilirubin. Since B1 could not be found in the urine, kaya hindi man siya water-soluble. If it is B2 nga nagsaka during hepatic jaundice, then of course, ma-positive ka for urine bilirubin. And since in cases of liver damage, if wala malang biliary duct obstruction, so urobilinogen could be formed and thus it could be present in the urine. As for hemolytic disease, urine bilirubin here is negative. Remember, ano gani nga types ng bilirubin ang gasaka sa hemolytic disease? That is your B1, and B1 is water insoluble. It is not readily filtered by the kidneys, so it could not be found in the urine. Thus, in cases of hemolytic disease and other causes of prehepatic jaundice, negative ang urine sample ta for bilirubin, whereas your urine urobilinogen would be positive. Moving on to the next question. In which of the following disease states is conjugated bilirubin a major serum component? A. Cholelithiasis, B. Hemolysis, C. Neonatal jaundice, or letter D. Erythroblastosis fetalis. So, again, conjugated bilirubin is also called as the obstructive type of bilirubin seen in cases of cholelithiasis. So correct answer for this one is letter A. As for hemolysis, the major bilirubin component here would be that of your B1. In neonatal disease, it would also be your B1, and same man with your erythroblastosis fetalis. As mentioned earlier, cholelithiasis is one of the causes of your post-hepatic jaundice, and it's quite important to know what differentiates cholelithiasis from other causes of jaundice, since patients with this type of disease will be exhibiting unique na mga manifestations that will allow us to diagnose or to differentiate that it is a type of post-hepatic jaundice. So the first one, patients will have dark urine. So dark urine here is caused by the increased level of B2 in the urine sample. Again, patients with post-hepatic jaundice will have pale or clay-colored stool. Remember that it is your stercobilin that gives color to the stool, and in cases of cholelithiasis and other causes of post-hepatic jaundice, stercobilin is not formed since B2 does not reach the small intestine. Of course, there would be jaundice accompanied by itchy skin, hyperbilirubinemia. Ang increase ng bilirubin sa blood is particularly that of your B2, and there would also be hyperbilirubinuria since B2 is readily filtered by the kidneys. There would also be increased alkaline phosphatase, gamma-glutamyl transferase, and 5' nucleotidase, because if you remember, these liver enzymes are particularly higher in cases of obstructive jaundice compared to hepatocellular jaundice. Hypercholesterolemia is also present, and the presence of increased serum bile acids. Next question. Which of the following conditions results from a transport defect leading to decreased hepatic uptake of unconjugated bilirubin? A. Gilbert syndrome, B. Rotor syndrome, C. Crigler-Najjar syndrome, or letter D. Lucey-Driscoll syndrome. So we have mentioned this one. This is actually a disease classified as a cause of hepatic jaundice, but the specific problem with the liver is with the decreased uptake of unconjugated bilirubin. So this is your Gilbert syndrome. So correct answer is letter A. As for Rotor syndrome, the specific cause of hepatic jaundice here is with regards to defective secretion of your conjugated bilirubin. Crigler-Najjar, on the other hand, is associated with the deficiency of the enzyme glucuronil transferase, and Lucey-Driscoll syndrome naman, guys, is associated with the inhibition of the conjugation process in the liver. So, in Gilbert syndrome, guys, remember that this is the most common cause of inherited unconjugated hyperbilirubinemia, but this is associated with a non-hemolytic increase in B1 levels, which separates it or which differentiates it from the causes of prehepatic jaundice. So, the problem again is either due to a defective conjugation system or due to a transport deficit in the sinusoidal membrane of the hepatocytes. Okay, so that is for your Gilbert syndrome. Next, your Krigler-Najjar naman, which is another cause of non-hemolytic unconjugated hyperbilirubinemia. There are two types of this disease. So type 1 is associated with the complete absence of the enzymatic bilirubin conjugation. So nag-undergo mutation sa genes nga ga-code for the formation of your glucuronidase transferase. That's why wala gidya glucuronidase transferase ang aton nga patient. Or sa type 2, which is less severe compared to type 1, there is just but a severe deficiency of glucuronidase transferase. So at some point, may ara pa ya presence sang enzyme, but it is also severe that it affects the conjugation function of the liver. And as what I've mentioned, we have here your Lucy Driscoll associated with the inhibition of bilirubin conjugation. So all of these diseases are associated with problems with the liver, and yung gasaka nga type sang bilirubin is your B1. So, ma-differentiate mo siya guys sa prehepatic jaundice nga B1 man ang gasaka because again, ang problem here is ara sa liver. Next, which condition is caused by deficient secretion of bilirubin into the bile canaliculi? A. Gilbert's disease, B. Neonatal hyperbilirubinemia, C. Dubin-Johnson syndrome, or letter D. Your Krigler-Najjar syndrome. So very obvious naman, deficient secretion would be letter C, your Dubin-Johnson syndrome. So we have already discussed the problem with Gilbert's disease and Krigler-Najjar syndrome. As for neonatal hyperbilirubinemia, again, nagasaka ang imo B1 since hindi pa mayo fully develop yung conjugation function ni liver. As for Dubin-Johnson syndrome, this disease is associated with the deficiency of the canalicular multi-drug resistant multispecific organic anionic transporter protein, which is involved with the ability of the liver to secrete conjugated bilirubin. So the removal of conjugated bilirubin from the liver cell and its excretion into the bile are defective, which is why, diba, sa Dubin-Johnson syndrome, ang gasaka nga type sang bilirubin is your B2. So this results in accumulation of conjugated and to some extent unconjugated bilirubin in the blood. Now, how do we differentiate your Dubin-Johnson from that of your Rotor syndrome, since both of them has problems with the secretory function of the liver? So a distinguishing feature of Dubin-Johnson syndrome is the appearance of dark stained granules on a liver biopsy sample. So amo lang ni siya guys. Your Dubin-Johnson and your Rotor syndrome are both causes of hepatic jaundice associated with defective secretion of your conjugated bilirubin. Dubin-Johnson is associated with hepatic pigmentation, but your Rotor syndrome is not associated with the pigmentation of the liver during biopsy. Moving on to the next question. Which of the following reactions will detect direct bilirubin? A. Furon, B. Berthelot, C. Jaffe, D. Van der Berg. So very obvious naman guys that the correct answer here would be letter D, your Van den Berg reaction. Remember again that your Furon reaction is associated with the diacetyl monoxide method for urea determination. Berthelot, on the other hand, is one of the colorimetric reaction utilized for ammonia determination. And then we have your Jaffe reaction, of course, associated with creatinine determination. So bilirubin measurement is actually based on the diazo reaction, also known as that of your Van den Berg reaction. So in this type of reaction, bilirubin will be allowed to react to diazotized sulfonilic acid to form azobilirubin, which will be measured spectrophotometrically. And the level of absorbance exhibited by the presence of azobilirubin will be directly proportional to the level of bilirubin present. Now, Van den Berg reaction is used to measure both that of your B1 and your B2 form of bilirubin. If we are to measure B1, we specifically identify the reaction as the indirect Van den Berg reaction. And this is also the reason why your B1 is also termed as the indirect bilirubin. B2, on the other hand, is measured via the direct Van den Berg reaction, and also the reason why your B2 is also known as the direct indirect bilirubin. So how do we differentiate that of the direct and the indirect Vandenberg reaction? So take note guys that for the direct Vandenberg reaction which measures your B2, there is no accelerator or solubilizer needed, and thus your B2 will be directly reacting with the diazotized sulfonilic acid. This is primarily because your B2 is water soluble, and therefore if present in the serum, it is not bound to your albumin. So no need na nga mag-add pa kita sang solubilizer to remove that of the carrier particle since it is present on its own. So conjugated bilirubin again, or B2, is being measured. Whereas for your B1 measured in the indirect Vandenberg reaction, an accelerator or solubilizer is needed. This is primarily because B1 is attached to albumin. And hindi pwede nga mag-react si bilirubin sa diazothiosulfonilic acid if it is still attached to albumin. Thus, we add an accelerator or a solubilizer. Last question under our liver function: which reagent is used in the Jędrusik-Groth method to solubilize unconjugated bilirubin? Remember again, to measure B1, we must add an accelerator or solubilizer. And there are actually two techniques with regards to your indirect Vandenberg reaction depending on the solubilizer added. So for Jędrusik-Groth, is it A, 50% methanol, B, N-butanol, C, caffeine, or D, acetic acid? So for this, Jędrusik-Groth utilizes your caffeine as an accelerator or solubilizer. So as a summary, we have here this table differentiating that of your Evelyn Malloy and Jędrusik-Groth, which are two techniques used in the indirect Vandenberg reaction. So if it is your Evelyn Malloy, methanol is utilized as a solubilizer, whereas for Jędrusik-Groth, it's your caffeine benzoate. For the optimal pH, the Evelyn Malloy technique occurs in an acidic na pH, whereas Jędrusik-Groth is alkaline. And the colored product that will be formed for Evelyn Malloy is red-purple, and for Jędrusik-Groth, that is blue yung colored product. Okay, so that ends our discussion with the questions again under the topics of liver functions. So if you have any questions guys or clarifications, please i-message nyo lang si Miss Ingrid and siya nang bahala nga mag-forward sa akon sang inyong nga questions. So again, God bless and good luck future RMTs.